The impact has been great. These are showing between the year 2000 and year 2004, the drop in our antigen tests, our infection rates in humans from 45% to 10%, our infection rate of the parasite in mosquitoes from 5% to 1%. An analysis last year showed this has gone down even further to about a 0.5% infection rate in mosquitoes and 5% infection rates in people. We're getting close to eliminating this infection. And to come back to that original graphic, if you recall, here's our onco-control arrow up at the top, which needs to go on forever. That's the red bar treatments that seem to have to keep marching on ad infinitum. And here is our lymphatic filariasis platform, which we hope will be able to stop our treatments in 2008 or 2009. And so when we talk about integrating programs, we have to think about in 2 or 3 years, what happened to our platform that we're integrating into. So a lot of people like to talk about the lymphatic filariasis and the onchocerciasis program, since they both use this medicine ivermectin as the twin programs, and they're easy to integrate. But actually, when you think about one being an elimination program and one being a control program, it gets a little bit more difficult to imagine how that's going to continue in the future. My daughter Alex is in the audience. She's a freshman at UGA. This is a snail drawing she did when she was about 8. Let's talk a little bit about schistosomiasis. I think she wants to be an art major here at UGA. You can use that in your portfolio. I know you're getting together. Really, schistosomiasis is like thing 1 and thing 2. They're really quite different programs compared to what I've been showing you. Even though in 2007 we celebrated 1 million treatments with praziquantel, remember we have to find money to buy these treatments. And it costs about 20 cents to treat a child with this medicine. And when you start talking about treating 1 million people, that becomes real money. So the integration of schisto with praziquantel to the lymphatic filariasis and river blindness programs with ivermectin albendazole has been problematic, and it's been slow. Getting at these kids is difficult. Now, urinary schistosomiasis, our approach to urinary schistosomiasis has been relatively easy compared to the other form of schistosomiasis that occurs in Nigeria, intestinal schistosomiasis. In urinary schistosomiasis, we can use what we call a reagent dipstick. You just dip it into someone's urine, and even if it's not grossly bloody, it'll turn colors to indicate there's blood in the urine, which in this case is basically synonymous with an infection with schistosomiasis, urinary schistosomiasis. So we can use this to map. We also can use this to evaluate the program, and we know that within 2 years of treating kids with praziquantel, the blood in the urine drops dramatically. Take a look at these 2 sentinel villages, Mankohat and Tenjim, which started off here in Tenjim with about 50% of kids infected or with blood in their urine. Here in Mankohat with 80% with blood in their urine. These are the 95% confidence intervals. And within 2 years, these numbers had dropped to well below 10%. Dramatic impact. But intestinal schistosomiasis is much more difficult, because to get at that, to be able to map that, we have to collect stools. You have to go and ask kids to go defecate and bring their feces back to you. Then you have to carry them back to the lab in a short period of time. You go through a very smelly procedure of preparing what we call a Cato-Katz test, and then you have to look at these under the microscope, a few inches from your nose. Now, a big development last year was the first big donation by another Merck, this is the German Merck called E-Merck, of praziquantel. And this was a really big development where E-Merck said that they would give the World Health Organization 200 million tablets over a 10-year period to promote the use or the control of schistosomiasis. And at our Nigeria program review in 2007, the World Health representative here at the opening session pledged 1.5 million tablets of praziquantel to Carter Center-assisted programs in Nigeria beginning this year. It's to be targeted at school-age kids, and the tablets are now in the port of Lagos, and we're working to get them out and start our activities. So that's a real breakthrough. Back in the year 2006, I wrote an article with colleagues about how difficult it was to integrate schistosomiasis with other mass drug programs. And the 3 points in that article were the challenges were the cost of praziquantel, the cost of extra treatment rounds, because at that point in time we could not give the praziquantel together with the other medicines, so we had to make another trip to the villages for treatment, and then the cost of mapping. Well, the cost of praziquantel now, in our situation in these areas, has been solved. The cost of extra treatment rounds has also had a major development. There have been some studies looking at the pharmacokinetics, the drug-drug interaction of praziquantel with the other medicines, ivermectin and albendazole, and it's been discovered that these medicines can be given together. There's no danger in giving these medicines together. And just in 2008, there was a report of what we call triple drug administration, triple co-administration of these 3 drugs. In Zanzibar, over 700,000 people safely treated. And indeed in Nigeria last year, we did a smaller study and 5,000 people safely administering 3 drugs without any problems. That study is now impressed. And so we can treat all 3 diseases at the same time. It's a lot of pills. These are the tablets that a tall individual would have to take. What you're seeing here is you'd have to swallow 5 praziquantel tablets, 4 omectazan tablets, and 1 albendazole tablet. It's a handful of medicines. But it is solving our issue of extra treatment rounds. What about the costs of mapping? Well, the WHO approach to mapping uses children as what we call indicator groups to decide what you need to do. In other words, you would go to a village, you'd go to a school, you'd get a bunch of kids together, and you would test them for either urinary or intestinal schistosomiasis. And if 50% of the kids were infected, you would need to go and treat the entire population. And if 20 to 49% of those kids that you tested were infected, you would only need to treat all the school-age kids in that community. And if 20%, less than 20% were infected, you would not do a mass drug administration in that program. Imagine you'd have 1 out of 5 kids infected and you wouldn't do a mass drug administration, but those were the guidelines. And this is a graphic that summarized testing of 22,000 kids in 747 villages. A big effort to look at dipsticks in the urine, how many kids had blood in the urine, how many communities would warrant treatment. And it works out like this. Of 747 communities tested, about half of those require some sort of mass treatment with praziquantel. And of that group, 2/3 require treating just school children, and 1/3 requires treating the entire community. It becomes very complicated, and when you start mapping this out on top of our platforms, as I showed you before, the map gets even more complicated as we try and move this program along. But what kept me up at night was wondering about intestinal schistosomiasis, which we can't test for. And we're running around and we've said, oh, well, half of the villages don't need praziquantel because they don't have urinary schistosomiasis. And the question was, well, how many of those villages we're not treating really should be treated with praziquantel because they have the other form of schistosomiasis? So in a very important study we did in 2006 done by Dr. Julie Gutman, an infectious disease fellow at Emory, she looked at what we called mistreatment opportunities for intestinal schistosomiasis, which we call schistosomiasis, Schistosoma mansoni. And this is what she did. She looked at the group of communities circled here, which we've been to, we assessed, and we said they don't need schisto treatment because they don't have urinary schistosomiasis. And she sampled a number of villages from this group. And she tested 924 kids. Here's some kids coming carrying their stool specimens on their heads from the night before. And lo and behold, she found that 25% of these kids had intestinal schistosomiasis that were not being treated. And if we looked by WHO guidelines at the community level, using these kids as an indicator group, of the 50% of communities not needing treatment for urinary schistosomiasis, over half of those needed to be treated for intestinal schistosomiasis. So we were running around doing all this mapping when really overall 80% of the communities needed to be treated for some form of schistosomiasis. And our question is, why are we spending this money and why are we doing this? Why don't we just treat everybody? So the cost of mapping is also falling off of our list, and we're moving toward a much